Hey, thank you. It's my pleasure to introduce Dr. Shapiro. Adrian Shapiro is an assistant professor in global health and medicine, the Division of Allergy and Infectious Diseases at the University of Washington. She is a co-author of the recent updates on the IDSA CDC ATS TB treatment guidelines. And today we asked Adrian to talk about the TB treatment and prevention for people with HIV. Adrian, please.
Thank you so much. I'm going to reattempt to share my screen, having done it once successfully. Okay, great. So thank you for that lovely introduction. And I am going to elaborate on that to say that because I am in the Department of Global Health, and a lot of my research focuses on TB prevention for people living with HIV in LMIC settings, in particular South Africa. This talk is going to have a little bit of a global bent. I'm certainly going to talk lots about local, US-based recommendations for treatment interactions, but also recognizing that many of our patients are coming from LMIC settings. And so I think it's always sort of useful to think about the global context for treating co-infection and preventing TB in people living with HIV. And I've also added into my mandate for this talk, talking about the medications used for HIV prevention, because increasingly we're seeing, certainly in LMIC settings, like where I work in South Africa, people who are taking preventive medications for HIV are also similarly at high risk for TB. So we'll incorporate a dual bidirectional TB treatment and prevention, HIV treatment and prevention, and talk about all the interactions in both ways. So this is my conflict disclosure statement. I've received grant funding as a clinical trial investigator from Merck, unrelated to this work. So for today's talk, I'd like to focus on describing the key drug interactions between antiretroviral therapy, or ART, treatment for HIV, including some of the newer long-acting antiretroviral agents used both for treatment and prevention of HIV. So interaction between ART and drugs used for the treatment and prevention of TB to help us design the most effective treatment combinations. And I'll also talk about the timing considerations and adjunctive therapies that may be used in treating TB in people living with HIV. So this is slide 1 that references alphabet soup. I have tried to expand on acronyms where appropriate, but you will have this slide for reference. And please just shout out if I start using abbreviations that are unclear. The world of TB treatment and antiretroviral treatment is inherently very acronym, and it's all 3-letter acronym prone. So I'll try to keep everything straight. So I don't think I need to provide much of a background to this group, but briefly, I will state that TB is the leading cause of death worldwide for people living with HIV. And globally, TB is responsible for about 30% of HIV-associated mortality. There is excellent evidence continually accumulating that providing TB preventive therapy to people living with HIV reduces TB incidence, TB mortality, and reduces overall mortality in excess of the benefit of antiretroviral therapy alone. So treatment of HIV alone there is additional benefit in providing TB preventive therapy and preventing mortality. And there is ongoing new evidence accumulating to direct the screening and treatment and prevention of TB. And here for this talk, I'm going to be using the term MTB infection, which I think we commonly have, for decades have been calling latent TB infection, or LTBI. But as we learn more and more about the spectrum of TB disease, ranging from infection to clinical disease, I'm very much in the camp of the newer terminology, where I think it's useful to think about MTB infection and then either a clinical or a subclinical transmissible or non-transmissible TB disease. So I'll try to make that distinction throughout. But if you see MTB infection and that looks weird, just translate in your head to LTBI. So the basic principles of treating HIV and TB really come down to the 3 big bullet points on this slide, and everything else is details. We'll go into the details, but all people living with HIV should be screened for TB, and this should happen at the time of HIV diagnosis, happen at any other time where there are symptoms. I mean, any other time in the same context where anybody would be screened and investigated for TB. But particularly thinking about at the time of diagnosis or at the time of entry or re-entry into care for people living with HIV, everyone should be screened for TB. And if TB disease is present, then TB treatment should be started immediately. If TB disease is not present, then if you're in a high incidence setting, like South Africa, where I do most of my work, TB preventive therapy should be started immediately. No further investigation is needed to start TPT once you've excluded TB disease. In our setting, we still want to demonstrate that somebody has TB infection or has a history of TB infection. So here we would recommend, once you've excluded TB disease, test with a interferon gamma release assay or tuberculin skin test, probably interferon gamma release assay, and treat MTB infection if the test is reactive. So the initial fork in the road is for someone with HIV, they either have TB disease, in which case should be treated, or they don't have TB disease, in which case it should be prevented. The other fundamental principle is all people living with HIV should be treated with antiretroviral therapy. The goal of ART is virologic suppression to achieve an undetectable viral load. And this should happen as soon as is feasible after HIV is identified. And we'll get into a little more details on the timing of treatment with ART and TB treatment in someone who has TB disease and HIV, who's not on ART. But for people living with HIV who are already taking ART when TB disease is diagnosed or TB infection is diagnosed, there's no indication to stop ART. So they should continue on ART and start TB treatment or start TPT. And again, we'll get into a little bit more detail on the evidence for timing of treatment initiation if someone is not taking ART. But everyone needs to take ART. The question is when, and it's soon, but how soon? All right, so this, I've tried to keep things, although unnecessarily wordy, I apologize, still pretty simple. So we've talked about the key principles of treating TB and HIV or using TB and HIV medications together. The key challenge for TB and HIV treatment or TB preventive therapy in people living with HIV is that rifampin and rifapentine both induce cytokine P450, a liver enzyme that metabolizes medication. And this causes serious and very dramatic drug-drug interactions, which in almost all cases with HIV medications reduces the level of ART in the system. So co-treatment with a rifamycin will reduce levels of ART in the system. And for people who are taking ART to treat HIV, this can result in virologic rebound and may result in emergence of ART resistance, which is obviously something we want to avoid. And then for people who are taking antiretroviral therapy as prevention for HIV, concomitantly taking with rifamycin can lower the degree of protection they have and increase vulnerability to HIV acquisition. So understanding which antiretroviral therapies are metabolized by P450 and are affected by this interaction is really the foundation of designing treatment regimens for people living with HIV or designing TB preventive therapy regimens for people living with HIV to avoid the worst of these interactions and avoid the worst outcome. If somebody is currently taking or wants to take medication that will have an interaction with RIF, there should be shared decision-making with patients to determine where is the priority. Is switching the we don't usually have many options in terms of TB treatment, but we do sometimes have options with TPT. So is switching a TPT regimen or choosing maybe a non-ideal TPT regimen preferable, or is changing the antiretroviral therapy regimen preferable to maintain overall good outcomes for both the TB and the HIV? So I think of TB, in the setting of these drug-drug interactions with RIF and many antiretroviral therapies, I think of there as being kind of like with blood transfusions, there's a universal TPT. So anyone with any ART regimen can take daily isoniazid for TB preventive therapy. It's compatible with all antiretroviral therapy. There is one universal ART, so an antiretroviral therapy regimen for treating HIV that has no interactions with RIF and can be taken unmodified, and that is tenofovir, emtricitabine, and efavirenz. It's a 3-drug combination, formerly known as a tripla in this country. And this combination is compatible with all TB treatment and all TPT. Unfortunately, we don't use this regimen very often anymore. This used to be the first line. This was the first 3-drug combination pill, 1 pill once a day to treat HIV. So it used to be very convenient. We now have better drugs for treating HIV, but they all have a little bit of complications when it comes to treating TB as well. And then in this talk, we'll also be talking about drugs used to prevent HIV acquisition, so PrEP, pre-exposure prophylaxis. And there are several different kinds of PrEP available that patients in our system may be taking. The main PrEP used is, fortunately, the universal PrEP, so Truvada or combination of tenofovir and emtricitabine. This PrEP is compatible with all TPT. It's compatible with TB treatment. No adjustments need to be made. We'll talk about a few other kinds of PrEP that can be taken, but not only is this the only universal PrEP, it's actually the only PrEP that can be taken to prevent HIV that can safely be taken with TB treatment. So really all other TPT options and TB treatment are likely to require some ART adjustment or some PrEP adjustment. So just again, I'm really going to hammer this home. It's RIF that's the problem. So RIF lowers the concentration of many ART drugs. This is, again, the universal combination, a tripla. It has no interactions, but it is no longer first line. A point to the global HIV treatment. So many folks coming to Seattle, to Washington State, to our neighboring states from other countries. If they are already on ART, which many folks are, they are almost certainly on the first line regimen for ART globally, which is tenofovir, lamivudine, and dolutegravir, which is abbreviated as TLD. And this can be given with TB treatment or TPT, but with TB treatment with daily rifampin, we have to make this pill, which is a 3-drug therapy given once a day. We have to take the dolutegravir component and give that twice a day to maintain concentrations. And then again, globally, second-line ART is a boosted lopinavir, so a combination of lopinavir and ritonavir. This can be given with TB treatment. This component of the medication needs to be doubled as well. It's a given BID, and that does increase the side effects. It's already given BID. The dose needs to be doubled as well. And then the other kind of key principle of ART interactions with RIF is that the drug TAF, or tenofovir alafenamide, which you'll see is very close to the TDF. So these two drugs, TDF and TAF, are essentially the same drug. They're both tenofovir. TAF is the more kidney-friendly, bone-friendly version. And there are many formulations of ART that have replaced TDF with TAF. But we can't give TAF with RIF. So often we can swap out TAF for TDF, but there are some drugs that only have TAF as an option, and then we need to come up with other options. So main takeaway from this slide: no TAF with RIF. And I know I showed you one alphabet soup slide. This is another warning slide because we're going to talk about different ART regimens for initiating, or what to do if you encounter patients on certain ART regimens. And there's a lot more alphabet soup ahead. So for people living with HIV not currently on ART, the most common regimens that we start, so first line ART, are a class of antiretrovirals called integrase inhibitors or INSTIs, along with 2 NRTIs. And so I've listed out the INSTIs here. The most common first line medication regimen that you will see in certainly in our part of the US, but I think throughout the country, is this 3-drug combination. It's called Biktarvy. It's bictegravir, TAF, and FTC. And it's, again, 1 pill once a day, which is very convenient for patients unless they need to take TB treatment or TB preventive therapy. So I've tried to do a little bit of color coding with the antiretrovirals. Anything in red has a contraindication interaction with rifampin or rifapentine. Anything in orange can be given, but there needs to be a dose adjustment. And then you'll see a distinct lack of green on this page. There are a few pages that have some green. But fundamentally, rifampin has interactions with all of the integrase inhibitors. It has contraindicated interactions with bictegravir, so Biktarvy is off the table. It can be given with dolutegravir. We'll talk about how to dose dolutegravir. Cabotegravir is the other integrase inhibitor that cannot be given with RIF. So the first line A1 recommended first line ART Biktarvy, not recommended to be given with TB treatment. Because RIF has sort of catastrophic interactions with lowering the level of Biktarvy. It can't be overcome with double dosing the way we can with dolutegravir. So still first line therapy, formerly the most common regimen you would see people being started on or being on would be dolutegravir plus Truvada or dolutegravir plus Descovy. And dolutegravir plus Descovy is TAF FTC. So from the previous slide, can't do TAF with RIF. So dolutegravir plus Truvada, the TDF FTC combination tends to be the first line therapy that we would typically start somebody on. The way to dose dolutegravir to overcome the interaction with rifampin and rifapentine is to dose the dolutegravir component BID. So starting someone on first line ART, dolutegravir and TDF FTC with the dolutegravir component BID. There is a 2-drug single pill regimen, dolutegravir and lamivudine, which is also a first line recommended regimen for people who have an initial viral load less than 500,000 copies and who don't have Hep B. So this can also be started in someone who is going to receive TB treatment or TB preventive therapy. But similarly, the dolutegravir component needs to be dosed BID, so 50 milligrams a second dose with a single tablet on the other time period.